So I don't have any disclosure to today, and yeah. So my talk will be about measurable residual disease in acute myeloid leukemia, and what is the clinical utility. So the objective will be MRD, what, why, when, and how, and what do we all know already, and acute myeloid leukemia specific MRD, and a few slides about clinical implication of pre-transplant MRD in AML. My talk will not I will not talk about ALL in my presentation. So what we all know that MRD, it was called minimal residual disease, and later on they call it measurable residual disease. And some people, they don't agree with both terminology, and they call it RDM, which is residual disease monitoring. So measurable residual disease is a small number of leukemic cells remaining in the patient during treatment or after treatment when the patient is in complete remission, and which ultimately lead to relapse. So in this cartoon, we can see the point 0 when the patient came to us as a new case. And when we say a patient achieve complete remission, which is just 1 log reduction on the left side, and this is based on just morphological remission. Unfortunately, those patients might relapse very quick, and we can see there is 3 curves. The first one, one patient will develop really deep complete remission, and he will continue to have it, and this patient will be cured. On the extreme, the first patient who just achieved morphological remission for short period, and he has this measurable residual disease persistent, and those patients will relapse. And in the middle, we have those patients who achieve good remission and negative MRD for some times, and then those patients relapse. And those patients, the one we don't know what to do with them, how frequent we need to do the MRD, and what type, what like modality we use. Like we can say the flow cytometry can detect from -3 to -4, and in certain center in Canada, they are able to detect up to -5 just with the flow cytometry. And we have the PCR, real time and quantitative. Next generation sequences already in the horizon, and it can detect, according to some companies, up to -7. Having said that, the key opinion leader think this is nonsense. Why we are bothering to measure MRD and why it is important? MRD is measure the treatment response. It is the source for leukemia relapse. We want to do the MRD at various time point during the treatment for prognostic information regarding the likelihood of relapse, and to correlate it with survival. To apply the rule of maintenance therapy, and this came, for example, from QZAR trial, and this is to prevent relapse by decreasing or suppressing the growth of measurable residual disease. In clinical trial, MRD, it can be like a surrogate marker for the outcome. So if we have a clinical trial and the endpoint is outcome, that can, the clinical outcome, so that trial can last for years. But if we use the MRD, we can use it as surrogate marker to see how fast patient can develop the MRD negativity. Identified patient at higher risk for relapse and what intervention we need to do. So if we found a patient is losing his MRD from negative to positive and become detected, we should make intervention, because if we ignore it, it is a clinical mistake. But the question is, does intervention will change the outcome? We don't know. And if we go to this 2007 study from MD Anderson, this is what we are telling our patient in the daily practice, like what is the chance of relapse in the first 2 years? And usually the relapse will happen in the beginning in the first or 2 years, and the chance in between 2 to 3 years is around 10%. But if we go to the second paragraph, and if we talk the patient who already like in remission and they pass the 2 to 3 years, on those category, if between 2 to 4 or 5 years, the chance will go up to 20%. It is exactly 18%. So it is really important to measure the MRD. There is two opinion in this case, because the people who will do the MRD beyond 2 years, here in Canada, for example, due to financial issues and financial crisis in the health system, it is they will call it as it is luxurious waste of money to do the MRD beyond 2 years. But if we bought this figure and we can detect patient early if they develop MRD positivity, we can save some patient. In this paragraph, if we categorize the patient to the old NCCN criteria with like favorable and intermediate and adverse, still we can see the risk of relapse in the first 2 years, and then in the adverse group it is go more high. And usually this group, the intermediate, is the group that I think with monitoring the MRD we can save some of them. Patient above age of 60, they have median duration around 11 months in the first when they presented as a new diagnosis. 60 years old, we give them 11 months remission duration, and this is the data from Princess Margaret in Toronto. So the natural history of MRD and what make it playing a major role. So it came from the QSAR AML 001. All of us is aware about this trial. It was published in New England Journal of Medicine. And it was first remission and age above 55, age between 0 to 3, and they will take de novo and secondary AML. And if the patient achieve remission, so they will randomize the patient after remission, not with the diagnosis, within 4 months, so 120 days, 1-to-1. Some of them will receive the oral azacitidine, and which is 1 tablet a day for 14 days, Q28 day cycle, and the other will receive just placebo. It is the problem with this trial is our center here in Canada, for example, was one of the center participating in this study, and the follow-up for 3 years, it was hardly to recruit, and it required doing a bone marrow aspiration for MRD every 3 months. And the patient has an opinion here, and they can refuse. So the trial was showing that your relapse-free survival for the placebo group is 4.8 months compared to 10.2 months, with 5 months difference and significant p-value. And if we look to overall survival, Also the same in the placebo group is inferior to the people who receive the oral azacitidine, which is expected. And the major issue here is in this trial, and this is what I mentioned, it required a lot of bone marrow aspiration to monitor the MRD. The point here is in this trial, it was to show the responder. So in the oral azacitidine cohort, MRD was positive during the randomization. So 37 who received the azacitidine, they achieve MRD negativity. And there is a group of placebo that they don't receive any treatment, no intervention, just they are monitoring the MRD. And in that cohort, 19% they achieve MRD negativity without any intervention. So this study or this trial emphasized that MRD can be used to monitor the response to the induction chemotherapy. So what we all know so far, MRD positivity is bad overall. MRD positivity pre-transplant also is bad. And this will tell us, for example, if your patient before transplant has MRD, before we will ignore it and take the patient for transplant, and we will say if we give him heavy chemotherapy, myeloablative, that might overcome. But with our knowledge now, we know we think that give him more chemotherapy, for example, it is similar to chemotherapy that take him to the morphological remission is better, or do something else before going for transplant. MRD analysis assess the treatment response and assess the need for transplant. And I did mention this in my previous talk or my previous slides. MRD in acute myeloid leukemia, for example, in acute promyelocytic leukemia, for the last 15 years or so, we get to know that monitoring the molecular test for ABL, especially like now they are not doing it for the low risk, but for the high risk. After you finish your maintenance, you can do it every 3 months for the first 2 years, and then every 6 months for the coming 2 years. And we know that if you notice your patient has lost the response and there is MRD become positive, his chance to get overt relapse in the first year will be 90%. So it's better to intervene early before the full relapse. For the common binding factor in version 16, translocation 821, monitoring with PCR is the best. For the others, I will not talk about Philadelphia positive ALL, though in the last 2 years, a lot of papers coming regarding the rule of monitoring the PCR. Shall we transplant everyone with Philadelphia positive, or we can wait and monitor the MRD? So this is kind of a debate here in Canada, at least. In this study, which is published in 2020 in JAMA, it is just a literature review, and they review around 1,500 articles. And to make the long story short, at the end, they have 81 articles with around 1,100 patients. 17 overall survival in 17 in article, the patient was around 3,000, and in 20 article disease-free survival, and in another 44 articles both. And their conclusion was the patient who has MRD negative is superior in the overall survival and also in disease-free survival compared to the patient who is MRD positive. So regarding the transplant, the timing to use MRD monitoring, like pre-transplant. So we are doing it for, let's say, 3 reasons. Number one, for prognostic implication of pre-stem cell, measurable residual disease will tell us what is the post-transplant outcome. The impact of conditioning, shall we go with myeloablative, reduced intensity conditioning, and what is the benefit from stem cell by MRD status. In this paper in GCO, in 2016, it looks to 230 MRD negative patients and 76 MRD positive, and there is around 48 with they came to the transplant. They were prior to transplant active leukemia. So they emphasize that usually the overall survival and progressive-free survival is inferior with MRD positive compared to MRD negative. And it is really clear here in this in the Kaplan-Meier that MRD negativity is superior in the outcome if you came for transplant. Regarding the next generation sequences, MRD by conditioning intensity, the next generation sequences is ultra deep, error corrected sequencing. The problem is will take up to 4 to 6 weeks. If we want to compare the myeloablative versus RIC, just for the time, for sake of time, we can say that in patient with no mutation, like next generation sequences negative, overall survival didn't differ on the basis of conditioning intensity, and the 3 years overall survival is 63% compared to 56 and p-value is not significant. But if someone came with detectable mutation before the transplant, the overall survival will be significantly worse, and this is very important information to the patient. So it is 43 compared to 61. So usually we will prefer to go with myeloablative in this cohort. Can allo-BMT abrogate increased risk of relapse from persistent mutation? And this is published or was in EHA 2019 from MD Anderson group, and also they emphasize that like allo-BMT with myeloablative, it could help. In this slide, on this Kaplan-Meier, we can see the people who has, like, for example, AML patient who didn't achieve complete molecular clearance, like MRD positive, before transplant, their outcome or the outcome will be worse. So AML patient who didn't achieve CMR benefit from allogeneic with marginal statistically significant. However, time-dependent analysis was not performed in this study. I'd like to conclude with saying that one of the great frustration in acute myeloid leukemia is that even patients who get into remission still relapse from the disease. And this is such a depressing thing to both patient and clinician. When we see a beautiful blood count, we look under the microscope and we see a morphological happy-looking bone marrow, and yet the disease is still relapse. And the reason for it is looking under the bone marrow or looking at blood count is just not good enough. It doesn't reveal the unfortunate log of the leukemia cell that are remaining at the completion of the therapy, and this cell are now collectively under the umbrella term of measurable residual disease. What is currently happening is that technology is such that you can always find leftover leukemic cell. Which one or which technology you want to use to find this leukemic leftover cells after therapy? The question is, what is the quantity and nature of the leftover leukemia cell? This is what does matter to the patient, because if you have few cells left over and they are being controlled by the immune system or by medication and not bothering the patient, that's one thing. But if you left it without monitoring and you don't check it, this might like grow and recapitulate for the original disease. What we try to do is how to standardize a quantity measurable residual disease, and we need to have like a formality at the center and then at national level. Shall we do it in like central lab? Because you don't want to do this, your PCR tested in DNA and the other doing it in RNA, what kind of kits, and at the end, or my last slide, will be MRD analysis have been the key tool worldwide in the leukemia. MRD analysis permit patient-specific guided to therapy rather than one size fits all. And in ALL, for example, the role of TKI switching, adding plina at certain like week 12 and 14, it might